There are only seven people to attend.
Yes, ma'am.
Okay, fine. So I'm sharing my screen. Are you all able to see the slides?
Yes, ma'am.
Okay, fine. So today I am supposed to take two sessions of yours, which is related to very much related to CHCWM, that is basically on the biomedical waste management. But the most important one associated with it is the infection prevention and control. So my sir, shall I start or hello? Dr. Panini, shall I start?
Yes, ma'am. You can start, ma'am.
Okay. So, myself, Dr. Sumita Soni, I am working as an associate professor at BJ Medical College, Ahmedabad, and also infection control officer of BJ Medical College, Civil Hospital, Ahmedabad. So, we will be discussing today about the infection prevention and control, the integrated program, IPC program, and how important it is. Today, we'll be learning. Why we want to discuss about this topic and how this topic is important to us. So, in any of the hospital setting, the bugs are already there, and you can't see the bugs, but still they will attack you, and you will get the infections with the organism which are not under your control. So, how do you, prevent it, and how do you get rid of it? So, there is an entire program which is called as the Infection Prevention and Control Program, which is meant uh, for the benefit of the patient, the visitors, the patient relatives, the staff, as well as the entire environment. So basically, this entire thing is revolving around something called as the healthcare associated infection, which occurs in a patient during the process of care in the hospital, or otherwise it was not present in him, into him or her, or incubating at the time of the admission. Initially, it was called as the nosocomial or hospital acquired or hospital infection, but nowadays it is called as healthcare associated infection, because it associates the infection to the healthcare, and occupational infections are also part and parcel of it. So very importantly, how this infection occurs. So when we talk about any of the infection, basically it occurs because of the interaction of three important domain, and these are the host, agent, and the environment. So until and unless they don't interact with each other, the infection will not occur. So these are the three important factors. So most important one is the agent factor, like all the organisms we see inside the hospital premises or hospital settings. It can be the institution, it can be the human, it can be the the reservoir also, or because they may be present inside the reservoirs also. There are certain factors which are related to the host, because these infection doesn't occur in a normal human being, this doesn't occur in a healthy human being. They occur only in the human being, those whose nutritional status is compromised, whose the having some underlying disease, whose susceptibility is compromised, who is at extremes of the age, or whose immune status is compromised. So these are some certain host factors. There are some environmental factors also. Normally, in a hospital setting, if a patient gets admitted in a ward, we don't usually see these infections to occur in those in those all those patients, they are admitted for certain reason, they are treated for that, and it is not necessary that they will acquire any type of healthcare associated infection. But when are the chances of acquiring the healthcare associated infection increases? So it also depends upon the environmental factor, that is specifically the hospital location, maybe in the critical areas, ICUs, post operative ward, the diagnostic procedures, if you do, chemotherapeutic patients and surgical devices you have put inside, exposure to the infected patients or healthcare workers and asymptomatic carriers. So once these all interact with each other, the infection occurs. And if this infection occurs in a hospital setting after the 2 days of admission, in our Indian setting we have defined is not as a 48 hours, but it is as a 2 days. Why 2 days? Because we don't write down the time during the admission of the patient. We are not monitoring our patient per se by using the time frame. So we have used you know the hours and minutes of the time. So we have kept it as a open as, and this is the definition given by AIMS. It is not my personal view keeping it 2 days. So within after 2 days of hospitalization, if anything occurs, it is attributed to the hospital setting and it is called as a healthcare associated infection. So why we should discuss about this topic, why this topic is important? So in the low middle, LMIC is the low middle income countries like our country. If you want to see the burden in our country, you can see the burden is more than, the large dots are there, okay, even in the pediatrics, and even orange dot and the large red this maroon dot is there. So if we see our country, we are with a more than 10 rate of HAI is more than 10. Okay, so it shows that it is significantly dependent, it is significant amount, and it is a lot of burden to our own country and countries all healthcare settings. So healthcare associated infection are definitely a concern in our country. We say that 7 to 10% of every 100 hospitalized patient, 7 in the high income and 10 in the low income and middle income country will acquire healthcare associated infection. Okay, and we also say that at least one healthcare associated infection. We also say that one third of the patient, in the ICUs in the high income countries are affected by one healthcare associated infection. So it's a very huge figure. And 1 in 4 healthcare associated infection in the long term acute setting are because of the multi drug resistant organism. So this is complicating the entire scenario more than if it is only the healthcare associated infection. So healthcare associated infection, its prevalence is increasing, as well as not only this, but also it is being acquired because of the organism which are the multi-drug resistant organisms. Okay, so HAI is important because it is considered as one of the adverse event. It is considered, if the HAI rates are high, it is considered as on the reputation of the hospital. If the rates are high, it is not that we are achieving some targets or goals. If the rates are high, that shows that our care delivery or our quality of care is not optimum, and hence we are not, hence they are getting the healthcare associated infection. It's a major public health concern, affecting the morbidity, mortality, even the quality of the life and patient safety. It is one of the very important outcome indicator of any of the hospital. So in our country, the burden of the healthcare associated infection, and if I say that openly, there are no portals or there are no data by and large available, but nowadays AIMS has made their own portal, and for the country level they are working hard, and they have registered public health hospital. We are also the part of it, their network program. And so at par, the data of all the hospitals can be compared because of this network. It also results in the prolonged hospital stay, more antimicrobial agent, more additional cost, high cost for the family, and also disability and all. So, but the bottom line is that these healthcare associated infections are largely preventable through the effective infection prevention and control measures. So this is one of the very important sustainable goals, sustainable developmental goals and important priority under the patient safety, that is a control of the healthcare associated infection. So national patient safety implementation network, not only countrywide but worldwide, talks a lot about the healthcare associated infection. It is also a part and parcel of the international patient safety goal. So that's why it is very very important to learn about it, to talk about it, and bottom line, I have told that it is preventable. So considering this fact, we should act upon it so that the rates can be reduced. So this slide I'm skipping, it is not meant for you. So this is the chain of transmission of infection. So any infection, I have told you that it can be transmitted through the epidemiological triad: infectious agent, host, reservoir, portal of entry, how it is transmitted, portal of exit, and the susceptible host. So most importantly, as a healthcare workers or healthcare professionals, what are our role? Our role is basically to breach this chain of transmission or to break this chain of transmission. So most importantly, how can you target the infectious agent? So rapid accurate identification and targeting them with the antimicrobial agents, so that will help you to control the one part of the epidemiological triad, that is the agent. Reservoir, we need to clean, sanitize, disinfect, sterilize our reservoirs so that it is not transmitted from one patient to another. Portal of entry, probably, when a patient is at risk, when we are basically performing any surgery, we are breaching the skin, we are the continuity of the skin is breached. At that time, there are all chances that from outside environment the infection enters. So proper attire in the surgery, appropriate hand washing. I'll say you that one of the most effective tool against the prevention of the healthcare associated infection is the hand hygiene and biomedical waste disposal, control of the secretions and excretions, and then means of transmission. So it can be a waterborne, foodborne, from fomite, from I'll say that it is from one person to another person by contact. So this contact is in a hospital setting. This is something, because as a healthcare professionals, we touch the patient, we touch one patient, we touch another patient. In between them, we do not take care of the hygiene, and because of that it is transmitted. So this is the indirect transmission of the healthcare associated infection from one patient to another patient, and we don't even realize it that we have transmitted a multi-drug resistant bug from one patient to another. So and there are certain patients, those who are having the aerosol infection. So these patients will be basically shall be kept, because they are generating a lot of airborne infection, so shall be kept in a appropriate isolation. Sterilization and disinfection is very very important. The environment of is also playing a big role in transmission of healthcare associated infection. So very importantly, we need to sterilize. We need to have, like if I talk about the OT, we need to have the appropriate environmental control like HEPA filters, you know and inside the OT we need to provide them the sterilized equipment. Portal of exit, wound care, because pus discharge from the wound, if wound care is not appropriately done, it will be infected. Catheter care, ventilator care. So these are all the portal of exit care is by using all aseptic techniques. Very importantly, how can you target a host? The susceptible host, underlying disease, if they have the any renal failure or diabetes, compromised status, we need to take care of them more. So this is the way we all shall break the chain of transmission of healthcare infection, associated infection. So infection prevention and control plan is a very smart plan, and we say that it starts with the surveillance, monitoring and auditing, antibiotic policy, reporting and isolation of the diseases, including the outbreak management and training. So this is very, very important. And today we are learning. This is also one part of the training towards the healthcare associated infection and the staff health. So how shall we design an infection prevention and control program? First and foremost, we need to document it. So we need to document the entire infection prevention and control program in view of reducing the healthcare associated infection in the hospital. And this can be done by designing the program in a structured way with the aims and objective into it, processes and activities and surveillance procedures into it. It should be based on the priority of a hospital. It should also be based on the national and the international guidelines, statutory guidelines, and scientific knowledge. So, very, very importantly, if I need to speak about something which guidelines you are supposed to follow, so it is the IPC guidelines for the healthcare facilities, which is released by the NCDC in the year 2020. It's a national guideline. It can be referred and followed and can be Googled at any point of time. It is available in the open domain. And they have talked about all the aspect of the hospital infection and prevention control program. So the hospital infection prevention control program should also talk about what are your target areas, because entire hospital is a big setting. A hospital prevention control program not only talks about the clinical area, it also talks about the support services, the ancillary services, the auxiliary services, and it mainly in the clinical area it talks about the high risk activities and high risk areas wherein the transmission rate of transmission of infection from one person to another is very, very high. And there we need to target more, there we need to take the precautions more. So example I will take is the aerosol generating procedure. Like when you are intubating a patient, it is a high risk activity. When you are handling the blood and body fluids, specimen and sharps, it is a high risk activity. And contaminated medical device and biomedical waste. So these are certain examples of the high risk activity. Infection prevention and control program, once we prepare, it's not once for all. We need to, because the guideline keep on changing, so we need to review it and update it at least once a year. And this update has to be based on the newer literature, or national or international, the outbreak which has happened to your organization, or also the trends of your own organization or hospital, and outcome of the audit process. So it is very, very important that you review it. If you don't have any changes, just minutize it in your hospital infection committee that we have reviewed the program, but there are no changes this time for this program, and it requires a review once a year. One important thing is that how do you design an infection control program? So before designing, we need to do a baseline assessment. This baseline assessment is basically based upon the validated tool which has been released by the WHO and the CDC. Anything you can take for long-term acute care facility by the CDC or WHO, that is a IFCAF tool, that is infection prevention and control assessment framework at facility level. These two tools you download, and you assess your hospital on their parameters, that where do we stand. And once we know, so they have given a marking system. So once we know that where we stand, from there we can start our next step. So the minimum things you might be doing, definitely, but certain are the areas of improvement, certain are the areas of focus. So these focus area you need to target in your infection prevention and control program, and these will become your risk reduction goals. These will become your targeted interventions. So basically, to run an infection prevention and control program, we can't run it without a multidisciplinary infection prevention control committee which coordinates the infection prevention and control activities. So the committee members can be the hospital administrator, microbiologist, the infection control specialist, the infection control officer, the infection control nurse, the nurse manager, CSSD staff, support service staff, and anyone you want to invite. Maybe you can invite the security, the sanitary supervisor, They are very, very important. The sanitation and infection prevention goes hand in hand. Mm, mm. So laying down the guidance for the implementation, establishing the risk reduction goals and the measurable objectives at least annually, and reviewing it monthly, and frequency of the meeting at least annual monthly, and minimum quorum and the minutes of the meeting has to be documented. This is something which is working at the organizational level. But if you want to see the impact of it, we need to have a team working under it. So it is not possible for all these high-end committee members, high-level committee members, to go to the ground and take the responsibility. So these infection control, so team has to be prepared, and the team looks into the day-to-day functioning of the infection prevention and control, surveillance activity, outbreak activity, and audit activity. So committee and team should not be same. But some team members should represent in the committee. So maybe the infection control officer and the infection control nurse, they should represent, and they will look into the day-to-day activity of the infection prevention and control. So it is said that in this program, to design this program, we need to have an infection control officer, which can be a clinical microbiologist or infectious disease specialist, depending upon their knowledge on the IPC practices. In the absence of the microbiologist, a surgeon physician can also be designated as a infection control officer. Infection control nurse is must. Every 250 bed, we should have a dedicated nurse, and should be designated based on the qualification registered nurse, and should have gone under the structured IPC training, infection prevention and control training. Okay, and what are their responsibility? That is the surveillance of the healthcare associated infection, compliance monitoring, working on the outbreak, education, training, and documentation on everything. So compliance monitoring basically can be for the hand hygiene compliance, transmission based precautions, standard precaution, PPE adherence, care bundles, disinfection and sterilization. And as I said, 250 bed, one infection control nurse is recommended. And also, if your hospital setting is large, so what at our setting, what we have done, we have 14 infection control nurses, but we have designated, because we have around 60 wards. So we have designated the active nursing staff as the link nurses who coordinate with the infection control nurses. So this program, it basically talks about managing the outbreaks also. And to run an infection prevention and control program, the management should support it in terms of the men and the material. Okay, so men, money, and the material is important. Without that, none of the program can succeed or sustain. So it is continuous and sustained manner, we need to have these facilities available. Funding is also very, very important. So for private organization, depending upon the previous year's experience, they allocate a budget for the infection control, earmark it, and allocate it. And they should also, the management should supply the adequate appropriate personal protective equipment, soaps, disinfectant, available at the right places to be used correctly. So what they need to ensure personal protective equipment at all point of use, and maintain the adequate inventory, use the PPE. The using the PPE is the risk based. Like in the psychiatry ward, touching the patient, we only need the gloves. The entire PPE is not to be worn. Removing the PPE after the use. And these PPE consist of personal protective equipment. Everyone has faced the COVID time, so everyone is now aware of this was the personal protective equipment. So gloves, protective gears, mask, apron, gown, boot, shoe cover, and cap or hair covers. Okay, adequate and appropriate facility for the hand hygiene, which is very, very important. We need to have the facility, the large wash basin, the hands-free tap, the soap, availability of the liquid soap, facility for the drying of hand without contamination, which is very, very important. Otherwise, again, while drying the hand, you contaminate your hands again. Hand rub facility, dispensers at the convenient point, or staff can carry it along with themselves. And every patient care area, at least one easily accessible wash basin with the running water facility is very, very important, because if you don't give this, then we cannot, we should not expect the compliance to it, because this is the basic facility which is supposed to be provided. Isolation and the barrier nursing facility. So there are certain conditions wherein, like if I talk about the tuberculosis patient, influenza patient, H1N1 patient, H3N2 patient. So respiratory diseases, mostly they require a isolation precaution. Also, the contact precaution is needed in measles, and mumps and all type of the disease. So they are kept in a contact droplet, and the airborne precaution needs the isolation in the isolation room. And airborne cases are supposed to be kept in the negative pressure room. The outside air can come inside, but the inside air without filtering should not be pushed outside to contaminate the environment. A appropriate aisle room is there, a side room is there, so directly you don't enter that room, and appropriate signages are also displayed. And all the time, isolation or the barrier nursing means we protect ourselves. So this isolation precaution is for the healthcare professional, not only for the patient. Adhering to the standard precaution all the time. So this is the key mantra for the entire IPC practices in all the areas, and all the time we need to religiously follow it. Standard precaution is one of the fundamental tenets of the infection prevention and control. Organization adheres to the hand hygiene guidelines. Everyone knows about it. I'm not going into the details of it. So these are the 5 moments of the hand hygiene: before touching the patient, before, after touching the patient, before any aseptic procedure, after blood and body fluid exposure, and after touching the patient surrounding. And types of the hand hygiene can be, the social hand wash, the hygienic hand wash, which we regularly do in a healthcare setting, and also the surgical hand wash, which we do while performing any of the aseptic procedures. So these are the 7 steps of the hand hygiene, and as per the WHO, and all the steps are supposed to be followed religiously. So it is supposed to be done when the hands are visibly soiled, but we can use hand rub when in between the patient, when there is no facility for the hand hygiene, and in a critical care setting you can do that. So in ICU, moving from one patient to another, you can use your hand rubs. So these are your actual hand hygiene steps. This is the surgical wash, hand wash, which is still elbow, and it is not only called as a wash, it is called as a scrub. Okay, it takes 3 to 6 minutes of the time to wash both the hands. So now comes the, we have a little bit touched upon it, that is a transmission based precaution. So airborne, droplet, and the contact precaution, we have talked about it. Identify and use of the appropriate PPE and the isolation. It also talks about the safe infection and injection and infusion practices. So the mantra is one needle, one syringe, and only one time. So not reusing the needle, and not recapping it, and we are supposed to use one needle for one patient only. So this is the WHO's toolkit. You can Google it and find it there. It also talks about the appropriate, because I have talked to you and shown you a burden that 1 in 4 is because of the multi-drug resistant organism. So hospital needs to define is antibiotic policy or antimicrobial uses policy. And if you want to learn more about it, you can download the antimicrobial uses policy or the standard treatment guidelines, which are being given by the ICMR. Okay, so ICMR guidelines are already being published for it, and you can see that your own hospital is following it, or you have some change in the flora you want to change, you can change as per the guidance of your microbiologist. Develop a system to monitor the drug susceptibility, and local antibiotic policy you can prepare, and you need to review it. You also need to restrict some of the antibiotics which are the high end. like colistin, polymyxin, linezolid, vancomycin. It should not be given just like that over the counter. And once the culture and sensitivity report is there, you can escalate or de-escalate your patient. Beyond this is the antibiotic stewardship program. Government of India is also now advocating it. So how much you have improved? It is a, I'll say that it is a multi-sectoral approach, or it is a it is multiple people are involved into it, like a pharmacist, pharmacology department, microbiology department, and the clinicians. So it is a collaborative approach to reduce the healthcare associated infection rate and also decrease the multi-drug resistant organisms prevalence. There are certain factors called as the engineering control to prevent the healthcare associated infection, and uh, they are basically the hospital engineering control. So biomedical engineer also becomes a very important key part of it, and it is uh, it talks more about the hospital setting, like the distance between two beds, design of the operating rooms, maintenance of the HVAC system, that is the heating, ventilation, and the air conditioning system, water management. So this is very, very important. We should also do some risk assessment when there is a construction and renovation going on, and there are validated tools available for it, and these tools will tell you about how can you assess the risk and how can you contain the risk. I already told you that sanitation and infection prevention control program goes hand in hand. So very robust housekeeping system should be available, and procedures should be available, at all the levels, frequency of cleaning, risk stratification, and this is very well defined and explained in the Swachhta guidelines and the Kayakalp guideline of Government of India. So others to organization, others to it, and we should also learn and talk about. So little bit detail I will be taking about the biomedical waste management to be handled appropriately and safely in my next session, which is more about the impact of the healthcare associated infection, when it can impact of the healthcare associated infection on the human as well as the human health and the environment. So that time we will learn more about it, because that is the next session of mine. But the entire mantra of the biomedical waste management is, first is the segregation at the site of generation, handling it with the appropriate ppe, collecting it in the color coded bag. This is the statutory requirement. We don't have any ways out of it. We cannot uh, you know skip it and dispose it, hand over it to the authorized vendor for the final disposal to the common biomedical waste treatment facility. Linen management, we all know, Government of India released the 7 days 7 color coded linen happens to be very, very one of the very important source of the healthcare associated infection, because if you don't keep the linen, change the linen, or if the linen is soaked, soiled, it can lead to a lot of infection from one patient to another, and in that particular patient also post operatively it can do. Then comes the kitchen sanitation and the food handling. It is very, very important, because that can be one of the source of the infection. The food outbreak can occur because of the supply of the stale food, or the rotten food. So this can lead to the outbreak inside the hospital premises. So kitchen sanitation and food handling, we need to have a dedicated storage, refrigeration, distribution at appropriate temperature, and the personal protective equipment to be worn while distribution of the food. Most importantly, that four healthcare associated indicators are there, which are called as the catheter associated urinary tract infection, ventilator associated pneumonia, and catheter linked bloodstream infection, and the surgical site infection. So we need to make certain bundle care. Bundle means these are the group of the preventive measures or precautions which can prevent this healthcare associated infection to occur in these particular cases, because it is said that if we enter any device inside a patient, the chances of getting the healthcare associated infection increases, or if you breach the continuity of the skin, again the chances of getting infection increases. So this is pre-op, intra-op and post-op care bundles, or I'll say the insertion, maintenance and the removal care bundle. These are supposed to be used. Uh, Analyzing the risk rates and the trends of healthcare associated infection by the data collection through the surveillance process, verifying the data by the team, and random sampling by using the random sampling method, surveillance of the high risk areas and the activities. Okay, we have already talked a little about it. And then surveillance of the monitoring the compliance of the hand hygiene, which is very very important. Minimum once a month we need to see that 5 moments of the hand hygiene, the 7 steps of the hand hygiene of the WHO is being followed or not. So that tool is also given. So WHO hand hygiene observation form is there. We need to assess our healthcare professionals, right from the doctor till the sanitation staff. We need to assess their compliance. Multi-drug resistant, this the lab will give you these results. And effectiveness of the housekeeping, we also need to see. Feedback is very very important, because whatever we are doing the data analysis, if the ground level persons are not knowing that what has happened in their wards, how they are supposed to act, how they are supposed to improve, so we need to give a specific feedback to each and everyone, those who are related to it. Okay, and outbreak management, definitely the early identification. So clustering of the cases in a ward, if you see in ICU, if you see that 5 patient is having the ventilator associated pneumonia with acinetobacter, it is an outbreak. So the appropriate investigation has to be done through a thorough investigation. And then we need to handle the outbreak adhering to the infection prevention and control guidelines. So most important part of the IPC is also the sterilization activity, and sterilization mostly done at the central sterile supply department. So what we say that a central sterile supply department need to have a unilateral flow or a U-shaped flow, starting from the cleaning area, drying area, packaging, sterilization, storage, and the issue counter. They should not be crisscrossing of any of the areas, and a zoning has to be there. Sufficient space has to be there. Separation of the clean and dirty area is very very important, and control airflow has to be there. So these guidelines are given by the Hospital Infection Society of India, HISI, and the WHO. And cleaning, sterilization and disinfection. Cleaning is the primary step which removes the visible biological material, so which will make the sterilization and disinfection more effective. So Spalding classification is followed for the sterilization and the disinfection. So for the intact skin, the device is called as non-critical. So low level disinfection is okay. If you use it the alcohol rub, that is fine. Mucus and non-intact, then semi-critical, high level disinfection like intubating, laryngoscope and all, scopies, and sterile areas of the body. So if anything is entering your major vessels or breaching your skin, like surgical procedure, the sterilization is mandated. So in the CSSD, these all procedures are followed. And then packing of the equipment. Most important is monitoring of it, monitoring of the validation and monitoring of the CSSD activity. So daily you need to monitor the temperature, pressure and the time, also the chemical strip monitoring, and at least weekly the bacteriological monitoring, all the biological indicators. Okay, and bovidic tape and leak test, these are the engineering validation. And with each load we need to should have the unique number, the expiry date, content description. So these are very very important. So if something happens, if your validation fails, you need to recall it, recall the entire load and do not distribute it. Okay, so if you have a batch processing system with a date, then only you will be able to do that. Okay, it also talks about the occupational health safety practices to reduce the risk of transmission of microorganism among the healthcare providers. And it talks about the pre I'll say the pre-exposure prophylaxis, which is about the immunization, and the post-exposure prophylaxis, which is about after exposure, how do you take care of it. So hospital should have a immunization policy and should have the hepatitis minimum hepatitis B vaccination for the kitchen worker, the typhoid vaccination, and the tetanus vaccination. These are the minimum essential supposed to be given to the any of the healthcare professional, including the outsourced staff also. Work restrictions, like if a patient, if a person, if the healthcare professional is having some coryza or respiratory disease, should not be placed inside the ICU until and unless conjunctivitis and smear positive, and appropriate personal protective equipment, and also the post exposure prophylaxis as per the NACO guideline we need to follow. So this is basically the entire IPC practice revolves around the breaking the chain of transmission of infection, and it is all our collective responsibility to break the chain of transmission of infection. So that's all from my side for this topic. Do you have any questions and queries?
Yeah, ma'am,
We can
ma'am, will you be sharing these slides?
slides. I think this is maybe I'll talk to Dr. Ruchika and maybe sharing it later on, not right now. Okay,
Okay,
so
because
shall we?
this was nicely explained the whole HIC of NABH, and
Oh, yes.
I think it was very useful.
Okay, sir. So I'll try to share it because the knowledge should be shared. And I hope you all have understood it. We will go to the next topic. Due to the lack of time, I am not able to not I have not prepared the template PPT of it, but the certain part, because it is more from your BHM 101 Block-3, the ninth chapter. So I'll be presenting from that uh, PPT, and it is about your impact of the infectious and hazardous waste on the human health and the environment. Okay, so shall we move to the next topic and we can take up the discussion later on,
Yes, ma'am, you can move.
because two sessions we have clubbed, so that's why. So a little bit because this I have taken the entire excerpts from your 10 CHCWM, your course material only, but I'll be elaborating it. Due to the lack of time, I was not able to compile the PP. I had been traveling. That's why. So most importantly, we'll see how a healthcare waste basically impacts the human, as well as the healthcare waste is impacting the environment also. So what categories of the healthcare waste we generally generate? So we all know. So I'm not going into the biomedical waste category right now because that will be taken up by someone else. And so these are more or less the biomedical waste category only, but not in that format of your the color coding and all. So the first category is supposed to be the sharps. So these consist of the needles, the scalpel, blade, lancet, knives, and the broken and unbroken glass, vials, tubes, pipettes, and all. Second category, which is the, I will say, it is mostly generated from the laboratory, or the where the research activities are going on, the stock of the organisms, so microbiology laboratory and the research laboratories. So these are the culture and the stocks. And third one is the human blood and body fluid. So a free flowing blood and blood components, any of the body fluid is supposed to be, we have seen in our five moments of the hand hygiene: exposure to blood and the body fluid. So these are all body fluids to which blood and the body fluids to which we can get exposed to. the pathological waste and the isolation waste, that is from the isolation wards. Uh, so healthcare waste, because we all know it comprises of 10% infectious, otherwise 85% is the general, and the chemical and radioactive are the hazardous other healthcare waste, which comprises of the 5% of the waste. So from where they can be generated? So inside the hospital, when we talk about, it can be generated, a huge amount is generated in the operation theaters, we all know that. So like, contaminated shops, chemicals, infected linen, gauze piece, body parts, everything you can, you name everything, it is generated in the operation theater. Emergency room, of course, it is the busy area of a hospital, and there in a lot of activities going on, life saving activities are going on, so a lot of consumption of the consumables and the drugs are there, and these all makes the waste a biohazard or the biomedical waste. The labor room, definitely blood bags. Most important is the dead fetus and the placenta, which comes out of the labor room. And the linen, soiled linen, we all know that a huge bleeding is there during the labor room activity. And when the mother is in the labor pain and delivering the child. The general ward, the sharp waste, all the biomedical category of the waste are generated, but they are not that much that we see in the labor room, emergency, and the operating room. Laboratory has a different setting, but they are considered as a high risk waste. And for the laboratory, the biomedical waste management rule says that we should pre-treat all the laboratory waste before submitting it to the common biomedical waste treatment facility. And it is the same with the blood bank also. So we need to autoclave it and pre-treat it before we are sending it to bins used to collect the waste. And the hospital linen and laundry, also the contaminated linen, so infected linen with the blood body fluid becomes a source of infection. Dental setting, the sharp swabs, and these are all the waste. So this we have seen. So these are all, basically these are all the source of infection, you know. So most important source of reason for the disease transmission. So one important impact to the human health is the transmission of disease from one to another inside the hospital setting, and the hands of the healthcare professional is very important. And I have told you that this indirect transmission is more rampant and more dangerous than the other ways of transmission of infection. The contaminated equipment used on the patient, poorly clean surfaces, and the rooms, and needle and sharp, definitely needle stick injury, and the biomedical waste contaminated with blood and body fluid, and the feces and the urine and the laboratory waste. So these are all the sources. So how it will be transmitted. So one important is poorly cleaned surfaces and the room. Second is the needles and the sharp. So one key point, because initially that was very rampant, and initially, on the initial days, these sharp waste management was not that much, because if you remember, those who are in the are the middle aged or in 50s and 60s, they all know that there were the boilers were there, and small instrument boilers were there, in which even the glass syringes are being boiled and used. So these all practices are gone. I will take the example of the Modasa epidemic of the hepatitis B, which was an eye opener to the entire country, and which has spread. I don't know how many of the lives have gone to the chronic hepatitis, and maybe some of them have gone to the hepatocellular carcinoma also. So this is the, so sharp waste management is very, very important. Biomedical waste management guidelines says it that clear cut we need to we need to segregate the sharp at the source of generation, and we need to do it in a puncture proof, tamper proof container, so that it is not a hazard to those who are carrying it or transporting it. Okay, so handling of the sharp is very, very important. And as per 2016 rules, the puncture proof resistant containers are supposed to be there. One needle, I have told you that, safe injection and infusion practices. One needle, one patient, one syringe, and never use it. So these are recapping of the needle, safe injection practices. We are bending right now also many a times, because the concept have not, I'll say, the percolated down to the interiors of our country. Therein still the blue color bags are being used, and from them it pierces out, and those who are carrying it, the housekeeping staff, they at that time they are getting the accidental needle stick injury. So we need to have, as per the biomedical waste guideline, which is a legal binding, which is a legal compliance, we need to have the puncture proof container for the sharp waste, which are of the two category. One is the glassware sharp, and second is the needle sharp. Okay, because their final disposal is different, that's why we need to segregate them. It's not like that we cannot keep the two sharps together. If we keep it together, then again, the needle will go to the metallurgy, and the glassware will go to the molten glass, and in the road resurfacing, and all this molten glass will be used for some reuse, not again for making the ampules and vials. Okay, so they are being reused, from repurposing is being done for some other purpose. So this is the risk from the infectious healthcare waste. Who are at risk? We all are at a risk, we all know that, and our environment is also at the risk. So how the risk is there. So those who are, it's not only the direct involved staff is at risk. Those who are in the sanitation activity are also at the risk. Those who are at the laundry, they are also at the risk. Those who are carrying the waste are also at the risk. And they are exposed to the blood and other spills, aerosols, and the needle stick injury. And needle stick, still we say that we need to, you all know that you need to submit one annual report for the biomedical waste management. In that annual report, when you read it, it will say the number of the needle stick injury to your staff which occurred in last 1 year. It shows that how efficiently you are managing the biomedical waste. The service providers are also at the risk: doctors, nurses, paramedics, everyone. And risk to the patient and the visitor, definitely, because they are, unknowingly, they will be put at risk, because they are not aware. This is because of their unawareness, they will be put at the risk. They don't know, and they are the victims of it. So like in ICU, that's why we say that do not allow more visitor inside the hospital, because we don't know that who are at the risk and who will transmit the infection from one patient to another. It is a risk to the community also, definitely. Improperly discarded, if they are reused in an inappropriate way, they will be the source of infection. Like initial photographs, I right now I cannot show it to you, but initial photographs of the rack pickers in every big hospital. There was all the rack pickers will come, they will stand. If it is a 4-story building, they will stand at the ground floor, and some of their sources will throw all the rags down, and they are all the biomedical waste, and mostly that was the plastic material and pints with the needle and all. So those were the days now gone, but still we have in memory, we have kept all the photographs. So these were very, very rampantly the rack pickers, and they are the huge source of transmission of infection, because they are selling these waste, and they are being reused in an inappropriate way. So they where the risk to them also, scavengers also, the children playing around, the community, even to the environment, even to the animals, everyone. Discarded sharps are picked by the drug users, and it spreads. So the waste handlers are at the immediate risk. They will be, because of the injury from the sharp, the radiations, exposure to the infectious waste, so they are all at the risk. So what is the risk? So most important risk is, first and foremost, is the transmissible infection, and that is hepatitis B, C, and the HIV. This is written in this order. Why it is written in this order? The chances of transmission of hepatitis B is far larger than the chances of transmission of the HIV. Okay, so we say that with the name of the HIV itself, we are panicked, but the transmission rates of HIV is far less than the transmission of the hepatitis B. And the good story about the hepatitis B is that we have the vaccine available for it, but not for the hepatitis C virus. So we need to take control all these infection and transmission of these infections. So what are the various modes of transmission? We have already talked about it. It can be through the airborne or direct contact, through fomites, through infected blood, and through contaminated water. So you can do the assessment of this risk by doing the risk assessment, which is like you can which is called as a hazard identification and risk analysis, which you can do by identifying the hazard, and you can also uh, determine what is the likelihood of that hazard and what are the outcomes or consequences. So this is called as a risk probability number of any of the hazard. So for healthcare associated infection, for the biomedical waste, every these small processes which are linked to the risk, you can calculate the RPN number and you can mitigate those risks. So infectious waste and its this I think we have talked about. So how can we prevent this? Is one is the sharp waste management. See, it is written, our outbreak of Gujarat only is given in the book also, that is a Modasa outbreak. Okay, so culture and stock. So for microbiology waste, we say that we don't have any other option except for the autoclaving of the waste. Okay, we don't have anything available, and hypochlorites and all, pouring that, these all days are gone. So it's an absolute procedure to get rid of the risk. Blood and body fluids, again, exposure, personal protective, as per the NECO guideline, we need to adhere to or respond and react to that risk. Pathological and placental waste, definitely, again, it will go in the yellow bag and it will go to the common biomedical waste treatment facility for the incineration. Okay, so incineration, plasma pyrolysis, deep burial are not now recommended except for the small areas. It is not recommended everywhere. And as per the schedule, and wastewater. So various wastewater, we need to, wastewater is also a potential infective source. So very importantly, every hospital should have, so liquid waste management, somebody will take up your sessions and they will tell you about, as per the schedule 2 of the biomedical waste management rules 2016, we need to handle this waste by the STP and the ETP plants to be installed in the hospital, and it can cause, the wastewater can lead to the antibiotic resistant pathogen transmission of the waterborne disease, vector-borne disease, and all. Public health, how it will impact the public health. So it can impact through the sharp waste injury, and that is hepatitis B 37%, HCV 39%, and 4% the HIV. And it also impact the antibiotic resistance. And we have talked about the wastewater, we have talked about the disease spread, and we have talked about the transmission of infection from one patient to another, and carrying the resistant organism from one patient to another. And impact of the healthcare waste on the environment is, we have One is the unsightly and objectionable dumps of the municipal. It will be a breeding site for the mosquitoes. It will be, in temperature, humidity conditions, it will allow the organisms to grow, and it will, spread the infection. So most importantly, we need to treat appropriately the biomedical waste or the hospital waste, so that it doesn't affect the environment also. And prevention policy and program and planning and training talks about, appropriate sharp management, standard precaution, barrier nursing, and effective management of the spills and wastewater management as per the guidelines. And pre-treatment wherever necessary, proper disposal, standard norms are supposed to be followed, immunization of the staff, and periodic surveillance and the record keeping. So, post exposure prophylaxis, for the hepatitis B, it is appropriately available. Hepatitis C, we don't have any vaccines yet. And HIV, we have the, antiretroviral therapy, but maybe if it is transmitted in the window period and 6 to 12 hours, we say that 2 hours, ideally it is supposed to be done within 2 hours of the exposure to the sharp. So that's all about impact of the healthcare waste management, and that's all from my side. If you have any questions, you can. Yeah, Pooja Das has raised the hand. May I know your question?
नो मैम, कुछ भी नहीं है।
Acha. So you all are, I hope I am able to explain the topic well, and you all are clear with the doubts, because the sessions are meant for the doubt clearing more than that, because these guidelines have been framed since long, and we had been discussing to come on the same page so that the errors are minimized. Any questions and queries?
नो मैम।
Okay, Dr. Panini, shall we close if the questions are not there? You can post later on also, you can post your queries, questions, and any requirement of the document through mail to Dr. Ruchika. She will get connected to me, and I will, share the guidelines and all. So Bhubaneswar classroom is available right now. I think they have left. So shall we close it? Okay, so we will close the session for today. Thank you so much for all your patient listening. Thank you. Thank you.
Thank you, ma'am.
ओके मैम, ओके,
Thank you.
थैंक यू
Thank you,
मैम।
madam. Thank you so much.